Good evening, everyone. So welcome to First Aid AMC Clinical Physical Examination class. So I can understand that most of you are already our course students, and you should be aware that physical examination course is the part of our full 5 months course as well. So as you have been doing our classes so far, this is also exactly the same part of your classes. But tonight class is not just your course class, it's also a free class for everyone who is preparing for AMC Clinical. So this is actually part of our just a solely physical examination course as well. And we have also students who are only joining our physical examination classes just for this 1 month. Okay, so welcome everyone to our free session tonight. So it's a very special class for us because as you know that for your AMC clinical, there is nothing important than doing your physical examinations right. Because I always say, and from our experience, that if you are the first time candidate or even second or third time candidate, if you're going to fail your exam, the most likely reason is that you're failing your physical examination classes. So that's why we say that failing physical examination cases, it is very common, but it can be avoided by doing a lot of hard work and practice in your home. So obviously we are not, we won't be able to like help you with practicing at home, which you will need to do by yourself, but we can show you each and every step of the physical exam so that you can do it on your partner, on your friends, or your study buddies. Okay, but there is nothing important than doing physical examinations right in your exam. And most of you will get at least 3 to 4 physical exam in your real exam. So you can understand that out of 16 station, if you get 4 station from physical exam, how important it is. And most of the time, physical examinations are not pilot cages. Sometimes one might be, but if you get 4 physical exam cages, at least 3 will be scored cages. So that's why the importance is really, really high for doing physical examinations right and correct. Now, there is a lot of guidelines, a lot of people do physical exam in their own way, but we will follow the Australian guideline, especially the guidelines that we follow in here when we are working in Australia. So each and every step that we are going to show you during these 1 month physical examination classes, those are the practical ways that we always do in our own practice. Okay, so if you ask me that what guideline should we follow, the guideline is that what we are actually doing in the classes. There is nothing else that you need for your physical exam. Each and every cases that can appear in the exam or that might be important in your exam will be discussed in the course anyway. Okay, so that's how we prepare you for physical exam. That's how much importance we give to the physical exam. A lot of candidates will not even have any idea how physical examination usually should be done in the exam, even after doing some course. Okay, so those courses that might offer you highest 3 to 4 classes on physical exam, which is obviously not enough for passing your AMC clinical. On the contrary, we have 1 month class just on physical examination, and we will have at least 8 to 9 sessions on physical exam. So that's more than enough. And that's how each and every one of you should prepare. And we have got a huge number of collection of cages in your portal. So as part of the course students, you will get access to the whole physical examination cages, both for face-to-face and online. Now, you might have got an idea that nowadays online examinations are not that much in amount. So previously during the COVID time, we gave a good amount of time for online physical examination rather than doing more on face-to-face. But now it will be reverse. We will be giving more time on face-to-face physical exam rather than online physical examination. Because online, it's all about getting an idea that how the physical examination should be done. And if you have a very good notes, you can easily follow that note and just do that explanation of the physical exam in your own real exam. So online examinations is easier in that way because you don't need to perform the physical examination on a patient just like the face-to-face. The face-to-face is a little bit harder in that sense because you need to perform physical examination and get the finding from a person in their exam. Okay, so let's move on. So far you might have an idea that the physical examinations is different from face-to-face and online examination, right? So we will give you some basic idea that how face-to-face usually happens and how online examination cases come in exam, so that you have some idea, and then we can move faster from our next class. So tonight we will mainly focus on the approach of physical examination, how it should be done, and we'll try our best to finish few cases so that you get some idea. But from next class, we will not discuss any approaches of physical examination or the initial discussion. We will just move very faster. Okay, let's start. So what are the basics of physical examination? The basic of physical exam is that you need to be very gentle with the patient. There is nothing important than being a gentle candidate in the exam, not just for physical examination, but for each and every cases that appear in your exam. The other important thing is that take permission for everything that you are doing. If you are going to touch a patient, you need to take permission. You just can't promptly just touch a patient without asking permission from him or her. Even if it's the same gender, like you're a female candidate and you are touching a female patient, before touching the patient, you need to say, I'm going to examine your knee joint now. Is that all right with you? So permission, permission, and permission each and every time. Even though if you take a permission as a whole at the beginning, still in each and every step of your physical exam, you need to take permission. All right. Now, in your own country, permission doesn't matter too much, right? Because those people sometimes we don't like bother about that. A doctor can touch us. That's the idea, especially in Asian countries. But if you are working in Australia, the thing is totally different. In here, touching someone means a lot. If you're touching a patient without asking permission, you immediately fail that case. Whatever, like how better you have done the physical exam, it doesn't matter. You touched a patient without asking a permission, you fail. So those are the smallest thing, but you need to be very careful. Make sure you explain what you are doing every step of the way. So if you're going to like examine the abdomen of a patient and you are going to palpate the abdomen to find out if it is tender, you need to explain that I'm going to feel your tummy. So if you feel any pain, just let me know. So this explanation is also very important. There are some physical examination which involve private part examination, like breast examination, scrotum examination, or gynecological pelvic examination. In those cases, whatever gender you are, you need to make sure that there is another person with you while you are doing the physical exam. And it's most of the time is one of your nurse who can act as a chaperone. So you can ask me that, can I ask my examiner to be my chaperone? No. Never ever ask the examiner that, examiner, can you please act as my chaperone? It's not needed, and please don't do that in the exam. So what you would say in otherwise that you just let the patient know that this is a private part examination. A nursing staff who will be here acting, acting as a chaperone throughout the examination. So that chaperone is must, not for everything, just for private part examination. Because of COVID, nowadays washing hands is must. Okay, so before starting your physical exam, you need to wash your hand, and after finishing the examination, you need to wash your hand. That's must. Okay. Running commentary. Now, that's running commentary is important for face-to-face physical examination. Face-to-face physical examination means that when you are performing a particular case, like let's say we'll be doing knee examination today. So in knee examination, you have done inspection of the knee. After finishing the inspection or while you are inspecting the knee, you are supposed to give running commentary to the examiner. Like on examination of the right knee, there is no scar, no swelling, no redness, no bruising, no visible deformity. So whatever you are checking, you need to give running commentary throughout your physical examination. And that's mainly for face-to-face examination. Okay, it's not like in geeky medics, you just do your physical examination and at the end you give a summary of your finding. It's not like that in your real exam. You have to give your finding every step of the way. So these are the main basics of your physical exam. Now, what is the difference between online physical exam and face-to-face physical exam? That's also important. Now, in online physical exam, the type of the question that comes is that, let's say a 28-year-old female coming to your general practice with a right-sided knee pain for the last 3 months. Then they will ask you that a medical student is with you. Explain what physical examination you are going to do on this patient to the medical student. Give your diagnosis and differential diagnosis. That's usually the online physical examination pattern. So in online physical exam, you are not supposed to do physical examination on a person because you can't do that. In that case, you are supposed to just explain all the things that you are going to do. Depending on who you are explaining, you can use medical jargon or you might need to use layman term. Like if you are explaining to a patient, you can't use medical jargon. You will need to use non-medical or layman terms. Okay. So it can be explanation of physical exam to a medical student or explanation to a patient, sometimes explain to examiner. Sometimes they also ask that discuss the physical examination with anatomical landmarks, which means that if you are checking a inguinal lymph node in a hematological physical examination, then you are supposed to say where you are going to palpate the inguinal lymph node. So that's anatomical landmark. Specify which equipment you are going to use. So if there is a particular task, initially you will need to explain to the medical student that for this particular exam, these are the instruments that we are going to use. But if this task is not there, then you are not needing to, so you don't need to explain or specify the equipment. Only time we specify the equipment is when it is coming in a task. Okay, so if the task asks you to specify, then only we do that. Otherwise, we are not supposed to do that. Okay, so these are actually the online physical examination questions that can appear in your exam. So let's give you a little bit idea that what's the difference between this online and face-to-face. So as you understand the questions pattern of online examination, we will go through the online examination explanation later on, that how we are supposed to perform it in the real exam. On the contrary, the face-to-face physical examination means that this is a solely physical examination case. You don't need to take history from the patient. It's just like you need to go into the room and your question will be same, like a 28-year-old female patient coming to you with a knee pain for 3 months. Your task will be different here. So perform physical examination on the patient, give running commentary to the examiner while you are doing the physical exam, and then give your diagnosis and differential diagnosis to the patient. What happens in this case that when you are performing the physical examination, you are performing it on a patient and the findings will be given to you from the examiner. Like let's say on inspection, you are saying that on inspection, there is no this. You are giving running commentary to the examiner. So you can use medical jargon at that time. Now, If some positive findings are there, then examiner will say that yes, there is redness, there is raised temperature, or there is visible right knee. So they usually don't give you a real patient in the exam. So those are just simulatory patient. So you might not get any positive findings when you are performing physical examination on that patient. If there is a particular finding that you need to have for that case, then examiner will give it to you after your running commentary. Saying so, if you don't say something particular, then examiner will not give you the finding of that one. Like, let's say you are supposed to say that you are looking for any visible deformity, but you haven't said that. So examiner will not give you that finding because you haven't talked about that. So that's how this is supposed to happen in the real physical examination case, which happen in face-to-face. Okay? Let's move on. So far, you guys have some idea, like, do you guys understand how the face-to-face and an online physical examination is going to happen? Great. Okay, let's move on. So when you are doing physical examination, your wipe approach is your initial step of physical examination. That's for both your face-to-face and online exam. So what is wipe approach? Wipe means wash your hands, then introduce yourself, take permission for the examination that you are going to do, and a proper exposure for that particular case. So that's your initial step before starting the physical examination with that patient. So first of all, when you enter into the room, you can start washing your hands. Or sometimes what people do that they first go to the patient, introduce themselves, then explain what physical examination they are going to do and take permission for that, and ask the patient to have a proper exposure. Followed by that, when patient is exposing themselves, they do the washing of their hands. Okay, so any of this is fine. You can either start washing your hands first and then you do the introduction and everything, or you can do the introduction, permission, exposure, and during the exposure, you can wash your hands. During washing your hands, there will be a basin in the exam room, and most of the time you get that soap dispenser. Sometimes if you just hold your hand underneath the soap dispenser, automatically soap will flow. Okay, so just use that and then wash your hand, and then there will be also a tissue paper. Just wash your hand with the tissue paper, and if there is gloves available, wear on a gloves. Okay, now it is a good idea to wear gloves during your physical examination in any kind of physical exam if gloves is available in your exam room. Sometimes if it is not needed, examiner will say, no need to wear gloves, just proceed. But the most important part where you have to wear gloves are the examinations where they give you mannequin. So they give you mannequin for breast examination, scrotum examination, any private part examination like a pelvic examination where you need to do a speculum examination, etc. Okay, sometimes ear examination. So mannequin examination, you need to wear gloves all the time. But in some other cases, there might not be any gloves available in that exam room. If it is available, then wear the gloves. That's good idea. Okay, so that's the wipe approach. This is a way that how online examination will look like. As you might be already aware that how online exam happens, that in online examinations, this is you as a candidate. There will be your role player or the medical student who will be talking to you. There will be an invigilator who actually just help you with the help you with the exam and moves you around each of the rooms. And there will be an examiner who you will not be able to see, and they will not talk to you in online examination. So online examination, examiner will not give you any finding, but in face-to-face, examiner will give you finding. Okay, so that's the difference. Now let's move on to the real physical examination case, and you will understand it much better. We will do knee examination today, which is one of the most important, and almost every month it comes in exam. Very common. And it's also one of the largest physical examination that you will ever do in your AMC preparation. You will see how much time it will take today. Okay, so knee examination. First of all, you should have a good idea about the structure of the knee joint. So you understand the knee joint, obviously. Have a look at the soft tissue structures which stabilize the knee joint. You can see that between the two bone, there is meniscus. So there is medial meniscus and lateral meniscus. Then there is two ligament, which is X-shaped, known as cruciate ligament. One is anterior cruciate and another is posterior cruciate. And on the both side, you have collateral ligament. In the inner side, you have got medial collateral, and in the outer side or lateral side, you have got lateral collateral. These are the 6 main things that you will be looking for any kind of damage in your examination. Okay? Knee examination. Now, for any kind of video, we always follow Geeky Medics. So Geeky Medics is very good with understanding how the physical examination should be done in your AMC exam. Many times Geeky Medics also does a little bit of mistake, but if there is something that we don't like, then we will obviously ask you to do a little bit different way. But most of the time, Geeky Medics is very good, well-structured way of doing physical exam. So we will follow a lot from Geeky Medics throughout this physical examination classes. Now let's see, a 28-year-old lady comes with knee pain while running for a few weeks. They usually give you that it is the right or left knee. Do knee physical examination, give diagnosis and DD. That is exactly how face-to-face physical examination works. So how we are going to do this case? So for knee examination, first of all, I will show you the summary of what it is going to be. Then we will see the video, and then we will go to the discussion in detail. Okay, so your approach or the summary of this knee examination is, first we will follow the wipe approach. Because patient having pain, we will offer analgesia. We will start with a general appearance, and then we will ask the patient to walk. So we check the gait, and we do the look, feel, move. That's a musculoskeletal examination. Any musculoskeletal, we will always follow look, feel, move, a special test. So in the look, we do it from 3 sides: front, side, and back view. So that's your inspection. After inspection, we do the palpation. Palpation will be usually on supine position like this. So you check temperature, tenderness. After palpation or feel, you do the movement, active and passive movement. And then you have got lots of special tests. So we have got patellar tap and bulge test. That's for knee effusion. After that, we have got some other special tests. So we have got Clark test. That's for chondromalacia patella. Then we have got patellar tilt test for patellar tendonitis. We have got patellar apprehension test for patellar dislocation. We have got anterior and posterior drawer test for cruciate ligament, collateral ligament test known as valgus and varus stress test. And for meniscus, we have got Apley's grinding test or McMurray's test. So these are the all tests that we are going to do for knee examination. Okay, let's come back. First of all, because this is your first time seeing how the physical examination works, let's watch the video. and get an idea how actually it happens in the exam. Okay, but there will be a lot of changes which you will see when we discuss the case. So this is just an idea that the physical examination will happen in your exam.
Hi, I'm Simon, one of the junior doctors. Can I just check your name and age, please?
Hi, my name's Grace and I'm 25.
Nice to meet you, Grace. Today I'd like to examine your knees. That'll involve me having a look, feel and move of them. Does that sound all right?
Yeah, that's fine.
Do you have any pain in your knees at all before we begin?
No.
Sorry. So if you guys don't hear properly, let me know. Okay. So you can see that first he has introduced himself and explaining what he is going to do. So that's the white approach that he is doing. This is
Hi, my name's Grace and I'm 25.
Nice to meet you, Grace. Today I'd like to examine your knees. That'll involve me having a look, feel and move of them. Does that sound all right?
Yeah, that's fine.
Do you have any pain in your knees at all before we begin?
No.
Lovely. If we could start by you standing up for me, and I'd like to watch you walk. Is that okay?
Yeah, that's fine.
So he's doing the gait. So you usually ask the patient to walk like this. And once patient is stand, like after finishing the gait, once patient is stand, you will do the inspection from front, side, and from the back. Now in here, patient is moving. You don't need to ask the patient to move like that. Actually, you can move and just do the examination. You can move to the front, side, and back. When you are going to the back of a patient, it's very much important that you say that now I'm going at your back to look at the back of your knee. Because going someone's back, it's not very gentle way, like if you don't take the permission first, okay?
All right, Grace, if you could just lie back on the bed for me.
Yeah.
So now you're going to do the palpation. So you have done the inspection. Now don't get stressed because we are going to discuss each and everything, every step of inspection palpation later on. Let's just watch the video that how it actually happens. And after that, we will discuss this thing.
Just going to have a feel of your knees.
Okay.
So this is temperature. Now, the one of the other things that see that when he was going to do the temperature, it said that now I'm going to assess temperature of your knee. So that's the permission. Even though you say that what you are going to do initially with the wipe approach, still each and every step that you are doing, especially before feeling or touching the patient, you are actually saying again that now I am going to feel your knee to assess the temperature. Is that okay with you? So that's important that you take permission. Now in here, he is actually doing the temperature using his both hand. This is not a correct way to do that. Use your right hand dorsum, just one right, like just right hand, not the both hand like this. So just use your one hand and compare the both side with your one hand. You can't assess temperature using the both hand at a time. Just using your one hand, using the dorsum of your hand, you should assess the temperature. Okay, and always make sure when you are assessing something, we always compare the normal side with the affected side. So if this patient having pain in the left side, you will first assess in the right side, the normal side first, and then compare it to the affected side. So normal side, we will always examine first, then we will do the affected one. Then you are doing the checking for tenderness. So when you are checking tenderness, especially starting with the quadriceps muscle and then the whole knee joint. See that how he is doing that. The knee is bent around 30-degree, and then you are using your both hand, especially for this, you're using the thumbs of your both hand to palpate the knee joint. Have a look how they are doing it. So each side of the knee joint, also the tibial tuberosity, head of the fibula, and the joint lines. And lastly, the popliteal fossa. So again, when you are checking the tenderness, first you will do it in the normal knee and then to the abnormal knee.
The other one.
So let's have a look to this again a little bit so that you can understand. So when you are assessing for tenderness in the knee joint, you need to assess first in the quadriceps muscle and then go down. Then you put your hands like this. So all the four fingers will curl around the popliteal fossa, and just using your thumb, you will do the palpation. So initially superior aspect of the patella, then the medial and lateral side of the patella, and then you go to the joint lines, you go to the tibial tuberosity, head of the fibula. So the whole knee joint should be palpated. There should be some formula in your head that this is the area where I am palpating. Okay? And when you are palpating it, you will need to look at the patient's face to see that if the patient feel any tenderness. That's also very important. While you are doing that, you will also need to give running commentary to the examiner that there is no tenderness on the quadriceps muscle, no tenderness on the patella, medial and lateral joint line, tibial tuberosity, and head of the fibula, and there is no tenderness, no mass in the popliteal fossa. So whatever you are doing, you are giving running commentary to the examiner as well. Okay.
And the other one.
Now in here, they have measured the quadriceps bulk, which is not needed. So forget about this one. Now after that, they have done the spatial test a little bit earlier. So now they're actually doing the bulge test to check for knee effusion. So this is how they do the knee effusion test, you can see. Or this is actually the patellar tap test. And then there is bulge test or sweep test. We will come to this video later on about this. These two we
Grace,
do for knee effusion. Okay.
I need to see some movements of your knees now. So first of all, could you just bend your right knee up for me and bring your heel up the bed? Lovely.
So this is the movements. Look, feel, move. In the movement, we have active and passive. In the active movement, you just ask the patient to bend your knee and then straight it. That's the only movement knee has, which is knee flexion and extension.
Okay. And could you do the same on the other side for me? Okay, and now just completely relax your legs. I'm going to do those movements.
And then you do the passive. Okay. So you do it by yourself.
Okay.
Your hand should be over the patella, and you will be trying to feel for any crepitation. If you feel any crepitation, that suggests possibility of either osteoarthritis or chondromalacia patella.
All right, I'm just going to pick up your ankles now as well. Okay.
So that's fine. We will now go to our discussion and we will come back to this later on. Okay. So I just wanted you to have an idea that how we normally do it. Let's move on. So in the approach, first of all, let's say you went into the room. So what you are going to do, you will first do wipe approach. So you will say to the patient, hi Jenny, this is Dr. Arshan. I'm one of the GP in this clinic. It's very nice to meet you. Patient says, nice to meet you, doctor. So then you can say, well, Jenny, I understand from the notes that you are having right knee pain for the last few weeks. I'm sorry to hear that, but now that you are here, we are going to find out the cause of your knee pain. For that, we are going to do knee examinations, which will involve me having a look at your knee joint, feeling for any change in its temperature or any pain, and also asking you to do some movements of your knee. And also we'll be doing some special tests to find out the specific cause of your knee joint pain. Is that all right with you? So you're taking permission. Now, for the purpose of the exam, I need you to have a proper exposure of your knee joint. So if you please can remove your long pants for me, but you can have your short pants underneath, that's not a problem. But I just need your full knee joint well exposed. Will you be able to do that for me, please? Yes, doctor. Then you can say, while you are changing the dress, I would give you some privacy to do so, and I will also wash my hands and come back to you. So that's how normally we will do that. Many times, if previously already this case has been done by some other candidate, patient already will be in shorts. They will not wear a long trousers or pant. So you most likely, you don't need to do that at all. Okay. So in that case, you will see that most of the time for this particular case, patient is already in a short. All right. So in that case, you can say that there is no particular exposure needed for this because I can already see your knee joint. So please give me a moment. I will just wash my hands and come back to you. Okay. So that's your wipe approach. Once you have done the wipe, you can also say that you are having pain for a few weeks. Would you like to have some painkiller for the moment? If patients say yes, then you can offer some painkiller, making sure patient doesn't have any allergy to that particular medication. Once you have done that, then you will say, well, let's start our physical examination. I would like you to know that throughout the examinations, I will give the findings to my examiner. So I will be using some medical jargon. Please excuse me for that. So that way, when you are actually saying something to the examiner, patient will not bother you or patient will not ask you questions for that because you have already said to the patient that this is what's going to happen. Then you say, well, now let's start our physical exam on general appearance. So first I'm going to just have a general look on you. So you say to the patient what you're doing, and then the running commentary will be to the examiner. So on general appearance, patient is sitting comfortably, no walking aids on his sides, and there is no protective posture that I can visualize. Now, general appearance, patient, whatever is the position of the patient, you will just say these 2 or 3 lines. That's just a general appearance of the patient. Once you have done that, if patient is lying down, then you can ask the patient, now, would you please sit up for me and also please walk a little bit for me, and I will like to assess your gait. Okay, so you can just ask the patient, now I would like to assess, would you please walk a little bit for me in this room? So patient will be walking. So you have noticed in the video that they are walking a certain distance to the room and then they come back. So once patient is walking, what you actually look for? You're looking for if the patient is walking comfortably, if there is any particular painful or antalgic gait, like if the patient is preferring bearing weight on particular side, and if the normal arm swing is preserved. Okay, so antalgic gait means that if you are in a pain in the right side of your leg, what will you do? You will not give too much pressure on your right leg. You will mainly just give all the weight on your left leg. That's what we call as antalgic gait. So you look for that. So when patient is walking to and from in your room, just like the video, you can give a running commentary to the examiner that patient is walking comfortably, there is no antalgic gait, and the normal arm swing is preserved. But if you see any particular difference, like if patient is not walking comfortably, just say that patient is not walking comfortably, seems like he's in pain on the right side. Also, I can see there is antalgic gait on the right leg, and normal arm swing is preserved. So it based on the findings that is given in the exam, you will just give the running commentary like that. Once the patient has done the walking, patient will stop, and then you will say that now I'm going to have a good look on your knee joint. First, I will have a look on your left knee, and then I will compare it with the right knee. Again, in the normal side, you will do the inspection first, followed by the abnormal one. Okay, so on the look from the front, so you will say, I'm looking from the front of your knee. In the front, what you look for? You look for if the suprapatellar and infrapatellar pouch obliterated. So what is this supra and infrapatellar pouch? It's just the space above and below your patella. Okay. So on the front, supra and infrapatellar pouch not obliterated. There is no swelling, scar, redness, no quadriceps muscle wasting, no bony deformity. So we always follow this particular inspection finding. So we do this SSRR BMD. So what is SSRR BMD? S for swelling, another is for scar, redness, rash, B for any bony deformity, and M for muscle wasting. So that's what we call as SSRR BMD. Okay, scar, swelling, redness, rash, bony deformity, and muscle wasting. So that we will use in almost every inspection that we are going to do. After you have done the front inspection, you go to the side of the patient and you look for any hyperflexion or hyperextension deformity. Then you go to the back. In the back, you look for any swelling in the popliteal fossa. You might have noticed that there are, in the bracket, we have written the explanation of what we are actually looking for. This is particularly for your online exam. In online exam, if you are explaining it to a patient, you can use the term popliteal fossa, but you will need to explain what is that. So everything has to be explained a little bit more. That's the reason why we have written this in the bracket. This is mainly needed for online exam, not for face-to-face. We'll come to that later on. So in the inspection or in the look, we are doing front inspection, side inspection, and back inspection. And these are the findings that we are looking for. And in here, you can see that this side of the knee is having effusion. You can see some visual deformity. And this is actually the hyperflexion deformity that we are talking about. Okay. Moving on to the palpation. So for palpation, patient needs to lie down on their tummy, on their back. So you will say that, now Jenny, would you please lie on your back for me? Patient lies on the couch on the back, and then you will say, now I'm going to feel your both knee to assess the temperature and also to assess for any tenderness on your knee joint. Is that okay with you? So you have taken permission for the both at the same time. That at least saves some time. So then you will assess the temperature, comparing the abnormal with the normal side. Okay, so just comment that if there is any rise of temperature. Where you get raised temperature, if the knee joint is infected, like if it is a septic arthritis, osteomyelitis, the temperature might be raised. So that's why we are assessing that. So first you assess the temperature, then you assess the tenderness. You can see that this is the anatomical markings where we check the tenderness for knee examination. So no tenderness over quadriceps. This is the suprapatellar and infrapatellar pouch. This is the patella. So you will be assessing patella each and everywhere. So medial side, lateral side on the top. Then that's your patellar tendon. This is your tibial tuberosity, the bony prominence. Then you have got the full joint line, medial and lateral. On the lateral side, you have got head of the fibula. Now, you can do it with the knee extended fully like this, or you can also ask the patient to bend the knee. Whatever works for you, it's fine. If you have done it with the bending knee, then just make sure at the end you palpate the popliteal fossa for any cyst, especially any Baker cyst. So that's the area where we will be checking the tenderness. Okay, so we have done the look and feel. In the feel, mainly temperature and tenderness is all that you need to do. Moving on to movement. Now, I can understand that there is a lot of questions coming into your mind. You can write it in the chat box, but once we finish the full physical examination, then I will answer your questions, because many times your questions will be answered while we are doing this case anyway. So you can write your questions. We will go through that at the end. Okay. So look, feel is done. Then we move to the movement. So movement, you already understand. You ask the patient active and the passive. So for active, you ask the patient, can you please bend your knee and then straight it? So active has only flexion and extension of the knee joint. Again, movement will be done first in the normal knee and then the affected knee. Then you do the passive. For passive, mainly we feel for any crepitus, which is found in these two conditions. So look, feel, move is done. Then we move to the spatial test. As you understand that there is a lot of spatial tests for knee joint, so you will need to be very quick in this case. First, to assess any knee effusion, we do patellar tap test and patellar bulge test. So what are these two tests for knee effusion? First of all, for patellar tap test, this is actually the main thing that we would do. Now, for any spatial test, you can just do it on the affected knee. You don't need to do it on the normal side, because you don't have that much time in the exam to do a whole lot of things in the normal and abnormal. So for a spatial test, we will just do it on the affected one. So how we do the patellar tap test? Patient's knee will be fully extended, and we will empty the suprapatellar pouch by sliding our left hand down the thigh to the upper border of the patella. So that's what you see here. With your left hand, you are going to just slide it from here down towards the patella, so that any fluid that has collected over here will go into the patella. So you slide any fluid with your left hand towards the suprapatellar pouch, which is here, okay? And then keep your left hand in position. Use your right hand to press down the patella. So your left hand will be in place, and with your right hand index finger, you will tap the patella downwards. While you are tapping it downwards, if there is a lot of fluid, you will feel that patella is floating. Obviously, right? So if there is lots of fluid in the knee joint, then you will find out that the patella is floating on that fluid. That's what we call as patellar tap test. And sometimes if there is fluid present, you will feel a distinct tap as the patella bumps against the femur. So that's the patellar tap test explanation. Now you can understand that why we have written it here in detail, because in online exam, you will need to explain it to the medical student. While in your face-to-face, you don't need to do that. You just say to the patient that now I am going to do some spatial test on your knee joint. First, I will assess for any collection of fluid in your knee joint by doing 2 tests. Is that all right with you? Just that. And after that, you will just do the patellar tap test and the bulge test. Once you have done it, then you say to the examiner, both patellar tap test and bulge test is negative. That's the only thing that you will say. So you can have a look to this video how we do the patellar tap test.
The patella tap test assesses knee effusion or swelling. One hand is pushed down the front of the leg to the top of the patella. This moves any fluid in the leg down the thigh to the knee. Keeping pressure on, the therapist will use the other hand to press down or tap on the top of the patella. If the kneecap doesn't move much, then there is little or no swelling. However, if it obviously moves up and down when pressed, then this is a positive test.
Okay, very easy to do that. Now let's move on to the Ball's test. Patellar tap test will be positive if there is a large amount of fluid collected in your knee joint. But if it is a small amount of fluid, then the Ball's test might be positive. So Ball's test is a little tricky than patellar tap test. So what you do in the Ball's test is that patient knee will be extended like this. Okay. And you can see that we are actually doing a swipe test. Swipe test and Ball's test is more or less same thing. In this test, what you normally do that you move all the fluid from here to here, and then again from here to here. Let's have a look. So you empty the suprapatellar pouch by sliding your left hand down the thigh to the upper border of the patella. So first thing that you do is that you, same like the patellar tap test, you will use your left hand to slide down all the fluids from here up to the suprapatellar pouch. So if there is any fluid collection in the top part, that will come down into the knee joint. And after that, stroke the medial side of the knee joint towards the lateral side of the joint. So this is the medial side. So you are stroking or swiping any fluid from the medial side towards the lateral side. And then stroke the lateral side of the knee joint, which will cause any excess fluid to move towards the medial side. Now, when you are doing that, you will see a bulge or ripple on the other side of the joint. So what usually happens in here, while you are swiping all the fluid from medial to the lateral and then lateral to the medial, you will be able to see a bulge on the other side. And the bulge is mainly the fluid is moving from here to here and then here to here. So that's called Ball's test. Now there is not much of a good video to show you for this, but we can see that if this one helps.
This next exam is called the bulge test. It tests for effusion or fluid on the knee. Inspect the knee, gently palpating the knee for any gross effusion, then taking the back of your hand, gently pushing up on the medial side of the knee, and then again on the lateral side of the knee, seeing if any fluid pushes medial or lateral as you're doing that.
Okay, so that's actually, it's not like quite a good video, but still you have got some idea. First, don't forget to slide all the fluid towards the suprapatellar pouch, and then just you swipe the fluids from medial to lateral and lateral to medial while you are looking for any bulge to the other side. That's what we call as Ball's test. Now, if you get patellar tap test positive, do we need to do the Ball's test? No need, because you have already got patellar effusion positive. But if patellar tap is negative, then only Ball's test is needed. Ball's test is needed. Okay, moving on to some other important special test. First is Clark test. Clark test is positive in chondromalacia patellae. So in Clark test, what you normally do, so this is actually the position. So the leg will be, knee will be extended, and you grasp the superior pole of the patella. So this is the superior pole of the patella. Okay. So you grasp the superior pole of the patella and displace it inferiorly. Okay, so first of all, knee extended, you are grasping the patella and displace it inferiorly towards this side. You will maintain this position and then you will apply pressure directly towards the patella downwards with your other hand while asking the patient to contract their quadriceps muscle. Again, you are going to say to the patient that now I am going to fix your kneecap by my hand and I'm going to press over your kneecap while you squeeze your thigh muscle. So when I ask you to squeeze your thigh muscle, would you please do that for me? Okay, so that's what you're going to do here. So first, you're going to fix the kneecap or fix the patella with your left hand, press the patella downwards with your right hand, and ask the patient to squeeze or contract their thigh muscle. What happens is that if a patient says that while contracting the muscle, there is pain under the patella, that suggests patient might be having a chondromalacia patella. Okay, we'll discuss what is this chondromalacia patella later on, but this is for chondromalacia patella and it's a very common cause of knee pain, especially chronic knee pain. Okay, let's see if we have got any video for this one.
In this evidence regarding the patient on the involved side and place the web space of the thumb on the superior border of the patella. Then ask your patient to contract the quadriceps as if they were to extend the knee while you apply downward and inferior pressure on the patella. Pain with movement.
So in here he hasn't done that one specific part. That's the only problem. But first of all, you can see here that he has stabilized the superior border of the patella. And then what you need to do is with your other hand, you will need to press the patella downwards, just like on the photo that we have shown you. And when you are pressing it downwards, ask the patient to contract or squeeze their thigh muscle. If the patient complains that he can feel pain under the kneecap, that suggests possibility of chondromalacia patella, and that is what we call as positive Clark test. Moving on to the next one, patellar tilt test. Now, while we are doing this special test, if any time you don't understand it, please ask me to repeat it. I'm more than happy to repeat it multiple times. Okay. So we are doing the Clark test followed by patellar tilt test. Patellar tilt test is positive in patellar tendonitis. So this is how we do the patellar tendinopathy or patellar tendonitis test. Now, unfortunately, there is no video of patellar tendonitis because normally no one actually do this kind of knee examinations. But for the purpose of exam, we need to check for patellar tendonitis because many times this is an exam case. So what we normally do, we ask so obviously patient knee will be extended. Have a look on the photo. In here, with your left hand, you tilt the patella upwards. So see that with this hand, you are tilting the patella upwards. When you tilt it upwards like this, the inferior border of the patella will be exposed. When the inferior border of the patella is exposed, you palpate underneath this area where you have got the patellar tendon. So what you do, you will say that now I am going to tilt your kneecap upwards and palpate a specific rope-like structure called patellar tendon. If you feel any pain during that time, please let me know. So with your left hand, you are tilting the patella upward. The inferior border of the patella is exposed, and then you are squeezing the patellar tendon with your thumb and index finger. When you are squeezing the patellar tendon like that, if patient complains that I'm feeling severe pain over here, that suggests patellar tendonitis or patellar tendinopathy. Okay, again, you are tilting the patella upwards with your one hand. So usually left hand, you will be tilting the patella. So if you press the superior pole of the patella, the inferior pole of the patella will be exposed. So tilting means just, you can easily do that if you even do it on your kneecap. You'll see that you can easily, with your one hand, you can tilt the patellar superior border. So if you tilt it over here, the undersurface of the patella will be exposed, and then just squeeze the patellar tendon with your thumb and index finger. Okay, so that will be your patellar tilt test, because we are tilting the patellar inferior border. Once you have done that, then you move to another test called patellar apprehension test that we found in patellar dislocation. Have a look how we do the patellar apprehension test.
In this video, I'm going to demonstrate the patellar apprehension test for patellar dislocation. To conduct the test, the patient is either lying supine or sitting on the bench with the knee flexed to 30 degrees.
So you don't need to have any bed like that in the exam. For patellar apprehension, patient can lie down and their knee will be flexed at a 30-degree position. So ask the patient to bend their knee, and then you can just do the apprehension test just like he's doing.
The quads should be relaxed to allow passive movement of the patella. With the thumb of both hands, press on the medial side of the patella to exert laterally directed pressure.
So see that this is one. So with your thumb of the both hand, you are trying to dislocate the patella from medial to the lateral side. If the patient already having patellar dislocation, while you are doing this, patient will be apprehended because of pain.
In a positive test, the patient may be surprised by the lateral displacement of the patella and feel uncomfortable or apprehensive as the patella reaches the point of maximal lateral displacement. The patient may even reach for your hands or attempt to straighten the knee to pull the patella back into relatively normal position.
All right, so that's your patellar apprehension test. Moving on to three other specific tests. These three tests are very important for your knee joint. So first of all, for anterior and posterior cruciate ligament, we're going to do anterior and posterior Dreyer test. So anterior Dreyer test, obviously it will assess the integrity for the anterior cruciate ligament. In this case, now this is one of the tests or one of the special tests which you need to do on the both knee, because you need to get an idea that how the normal knee feels like. Because anterior Dreyer test means the knee will give away. To understand that if this is the normal giving away of his knee, you need to do it on the normal leg first, followed by in the abnormal knee joint. All right, so remember that, because a lot of candidates forget about that. Have a look at what we are doing for anterior cruciate and posterior cruciate ligament. So I will show you the video and you can go through the discussion later on. So Geeky Medics actually have done this Dreyer test. So in this case, again, what you are going to say to the patient that, now would you please bend your knee for me? And I'm going to push your knee backwards and forwards to know its integrity. Is that okay with you? So you're going to pull the knee outwards. So pulling outwards, that's actually anterior drawer test, and pushing backwards is the posterior drawer test. Have a look
Okay,
how you
Grace,
do that.
I'm just going to examine the ligaments in your knee now. Let me know if you have any discomfort at all and we can stop.
Okay.
Or you can just do in this way. That's also fine. So see this one, you are now pulling it outwards or pulling towards you. So the position is important. Using your both hand, you will curl your 4 fingers around the knee joint and you will use the thumb of both hand and you will try to pull it towards you. And if you see that the knee joint is giving away, that suggests there is lack of stability of the anterior cruciate ligament. Have a look again.
Stop.
Okay.
And now you're pushing it backwards or downwards. So pulling it towards you and then pushing it downwards. So pulling towards you is the anterior cruciate ligament test or anterior drawer test, and pulling it downwards, that's posterior drawer test. Clear? Yes, Dr. Shwina, you have to do all these special tests on the knee joint. That's unfortunate, right? But that's how it is. So anterior cruciate and posterior cruciate is done. Now moving to collateral ligament test. So we know that we have medial and lateral collateral ligament. So for medial collateral ligament, the test that we do is called valgus stress test. And for lateral, we do the varus stress test. Sorry, so posterior drawer test, if you look at the video, Dr. Shwina,
Let me know if you have any discomfort at all and we can stop.
Okay.
so see that he's pulling it outwards, that's anterior, and now he's pushing it downwards, that's posterior. Okay. All right. Medial and lateral collateral ligament test. For medial collateral ligament test, which is also called valgus stress test, let's say we are assessing the right knee. Okay. So this is the right knee. Now your medial collateral ligament is on this side. So this is the position that you need to have for this particular test. For medial collateral ligament test, you will not touch this ligament. So your right hand should be around the medial border of your ankle or medial border of your leg. And your left hand should be around the lateral border of the knee joint. Okay. Now think about it. If you need to stress this ligament, where will you move this knee or where you are going to move the leg? Are you moving it outwards or inwards? Guys? Outwards, right? Dr. Anil, very good. So that's the mechanism of straining this ligament. All right, so you will need to move this leg outwards. If you're moving it outwards, then you will be able to strain this ligament. And if the patient complains pain, that suggests there is a possibility of medial collateral ligament injury. Exactly different or opposite will be in the lateral collateral ligament, where you will do the exact opposite thing. We will come to that. So have a look how medial collateral ligament test should be done.
In this video, I'm going to demonstrate the varus stress.
So they have done the lateral here. Let's see if we have got the medial one.
In this video, we will discuss and demonstrate the valgus stress test to assess medial collateral full extension, secure the ankle with one hand.
So now this one is the left knee they're doing, right? So your mechanism is same. Whatever is the knee joint, you will be thinking that you are going to strain the medial side of the knee joint. So for medial collateral ligament, your positioning would be like this. So
And place
see
the other
over
hand
here.
around the knee so that the thenar is against the fibula head. Then push medially against the knee and laterally against the ankle in an attempt to open the knee joint on the inside. And if possible, try to palpate the medial joint line for gapping and pain.
So what you are doing, see this one. So if you need to strain the medial collateral ligament with your left hand, you are going to pull it outwards. And with your right hand, you will be pushing the knee inwards. So both force should be done. See that how he is doing it outwards
Now
and
let's look
pushing
at the
it inwards.
variation in 30 degrees of.
So that's actually how you need to do. Now, a lot of people sit over here and then do it. Sometimes if in the exam, the patient is very heavy, like Australians male are very heavy, like even 140 kilos sometimes. Now that knee for you, if you are a 50 kilo patient or 50 kilo candidate, then doing this knee will be really heavy for you. So for that case, you can even sit on the couch and do it, like you can keep the patient's knee on your lap. That's fine, but you just need to take that permission from the patient. If it's very heavy for you, you can always support it on your lap. But if you don't want to go through a lot of problem, then just try to do it in this way. All right, let's have
Flexion,
a
which
look
was
again.
thenar, is against the fibula head.
So the best way, it's not underneath, best way is on the lateral aspect of the knee if you put your hand, okay? So to strain the medial collateral ligament of the left knee, your right hand will be on the outer aspect of the knee joint and your left hand will be on the inner aspect of the ankle joint. The main thing is you need to think in your head which one is I'm going to strain. I'm going to strain the medial collateral ligament. So what should be my position to do that? Or what is the easiest position for me to do that? If you think in that way, it's become very easy. Otherwise, you will just think, where should be my left hand? Where should be my right hand? It's not that complicated if you do it on a patient or on a person at your home. Just practice that. You will see that it's not that hard. Okay. Now come to the lateral collateral ligament test.
In this video, I'm going to demonstrate the varus stress test for lateral extended. To perform the test,
So that was actually I was talking about. So see that this patient, so if it's heavy for you, you can always do it in this way. Now you're doing the you're doing the lateral collateral ligament test. So where is your lateral collateral ligament of the left knee? On this side. So obviously you can't keep your hand over here. So what you will do, with this hand, you will give pressure on the medial side of the knee joint and your other hand will be on the lateral aspect of the ankle joint. Have a
instruct
look.
your patient to relax as much as possible. Grab onto the lower leg with one hand just above the ankle joint and fixate with the other hand on the medial side of the femur. Apply lateral rotation in the knee joint.
Lateral rotation is not needed.
And perform passive adduction in the knee joints to put stress.
Now tell me, if you need to strain this lateral collateral ligament, where are you going to move this leg, inwards or outwards? So if you need to strain this, you will need to pull it inwards, right? If you pull it inwards, then this ligament will be strained.
Rest on the lateral collateral ligament.
See, you're also pressing it over here as well.
Consequently, perform.
So that's only that you need to do. You don't need to do multiple times. Is this something clear for you guys? I know this is a little tricky, but if you want me, I can always repeat it. Clear for everyone, the medial and lateral collateral ligament test? Good, very good. Now the last test for this knee examination is your meniscus tear test. So you have got medial and lateral meniscus, but you don't need to do different type of test for medial and lateral. You can do one test for both medial and lateral. Just moving it out and in, that will do that. Let's have a look how we do it. Now, for meniscal tear, there are lots of tests available. You have McMurray's test, you have Apley's grinding test. We will do the both. Whatever you want to do, you can choose in your exam. Have a look at this position. So for Apley's grinding test, the patient will be lying prone. So now this is the only knee examination where patient needs to lie on their tummy with their knee flexed to 90 degrees. So the knee is flexed to the 90 degree. You are going to apply axial pressure to the foot. So you are going to press it downwards. So knee flexed 90 degrees. Then you can see that this is the leg of the patient or foot of the patient. You will hold the foot like this and give an axial pressure downwards and then rotate the tibia internally and externally. Okay, let's have a look how we do that.
This is going to be the Apley's test for meniscal damage. Leg with your own leg and bring the
So patient is lying prone position. Now you can see that he is giving a pressure with his leg to the patient, which you will not do. This is not needed. You will just passively flex the knee joint
into 90 degrees of flexion. While you give this traction, perform lateral rotation of the tibia and medial rotation. You are looking.
Now in here, they haven't done the axial pressure, which is not even important. Like if you want to do that, that's fine. If you don't do that, that's also fine. Axial pressure is not the most important part. The main part is medial and lateral rotation because that will give you the pain.
Looking for excessive rotation compared to the other side or discomfort. Then repeat the same procedure while you are giving compression.
So they're now giving the axial compression. Now the thing is that if you do the axial compression first and then the rotation later, that's also fine. So I would say that rather than doing it multiple times, just hold the foot like this, give an axial pressure first and then rotate it. That should do it. All right. Or if you want to do it twice like this, that's also fine. Have a look again.
For excessive rotation compared to the other side or discomfort. You are looking. With this traction, perform lateral rotation of the tibia and medial rotation. You are looking for excessive rotation compared to the other side or discomfort. Then repeat the same procedure while you are giving compression.
Compress, lateral rotation, medial rotation.
In this case, you are looking for decreased rotation or discomfort. If rotation.
Okay, so that's what we call as Apley's grinding test. There is another Applis test. You
90
can see it
degrees.
here.
The examiner stands on the side of the examination table with both hands on the plantar aspect of the subject's foot and heel. The examiner medially and laterally rotates the tibia while applying an axial load through the tibia. The same medial and lateral rotation should then be repeated with a distraction force. A positive test with compression is indicated by pain, clicking, and/or restriction and may represent.
Okay, so there are mainly two kind of tests that you are doing. One, now in here they have put the leg over the patients. It's not needed. You can just do it twice without putting your legs. Putting the legs doesn't look good. Okay, so you just you do like this, axial compression and medial and lateral
Medial
rotation.
and lateral rotation should then be repeated with a distraction force. A positive test with
And then-
compression is indicated by pain, clicking,
Okay.
and/or restriction and may represent.
So that's Applis grinding test for meniscus tear. Now, if we look at the McMurray's test,
Hey everyone, welcome back to Clinical Physio with me.
This is going to be a video on the McMurray's test for meniscal damage.
so for McMurray's test, you don't need to ask the patient to change the position. That's the only benefit of it. But you can do any of these two. That's totally fine.
According to research done by Blythe et al. In 2015, the diagnostic accuracy of this test was as low as 63%. Have your patient in supine-lying position with the tested knee fully flexed. Then rotate the
So knee is fully flexed and you can do it passively.
tibia medially and bring the knee into extension.
Okay, rotate the tibia medially.
You want to
and then you need to bring it on extension. Have a look. This is quite easy than that Applis grinding test.
with the tested knee fully flexed. Then rotate the tibia medially and bring the knee into extension. You want to repeat this process a couple of times with a different angle of knee flexion in order to test the whole posterior aspect of the lateral meniscus. In order to test the medial meniscus, bring the knee into full flexion and laterally rotate the tibia.
Okay, so that's the main thing. So just need to make sure that you are rotating it medially and laterally, and then so you are flexing the knee first, and then you are doing the medial rotation, and then you're extending the knee, and then for other one you do the lateral rotation of the tibia, and then just do the extension. Have a look again.
With the tested knee fully flexed.
Fully flexed.
Then rotate the tibia medially and
so you are now rotating the tibia medially, so in your inwards.
bring the knee into extension.
And then extension. Okay.
You want to repeat this process a couple of times with a different angle of knee flexion in order to test.
So when you do the medial rotation, you are checking the lateral meniscus. So that's the main thing that you don't forget. When you are doing the medial rotation, you are checking the lateral meniscus.
The whole posterior aspect of the lateral meniscus. In order to test the medial meniscus, bring the knee into full flexion.
So full flexion and lateral rotation.
And laterally rotate the tibia.
All right, guys. So that's your McMurray's test for medial and lateral meniscus. Okay. So that gives you the whole knee examinations, and that's actually a lot, right? So all the explanation of this assessment is written in here. That's mainly for your online examinations, that how you're going to tell it to the examiner or you're telling it to the medical student. So if we give you a summary of the knee joint now, so you can understand that first of all, we are starting with the approach. So wipe, general appearance, asking the patient to walk. Then we do the look on 3 sides, front, side, and back. Then do the palpation, temperature and tenderness, movement active and passive. Then we go for a special test. For patellar effusion, we have got patellar tap test and pulse test. We know how to do that. After that, we move to the others. So Clark test for chondromalacia patelli. In chondromalacia patelli, you are mainly pressing over the superior pole of the patella, pressing the patella downwards while patient is contracting the quadriceps muscle. That's for chondromalacia patella or Clark test. Then you have got patellar tilt test where you are tilting the superior border and inferior pole is exposed and you are palpating or squeezing the patellar tendon. Then patellar apprehension test for dislocation. We have got drawer test where you are pulling it outwards and downwards. You obviously remember the collateral ligament. And lastly, we have got meniscal examination. One is Aplis or McMurray's. After finishing that, you will just need to tell the examiner that I would like to complete my examination by doing the ankle and hip joint as well. You will just say that because no joint examination is fully finished until you do the one joint above and one joint below. So you are doing knee joint, so one joint above is your hip and one joint below is your ankle. So just say that you would like to complete that. Once you have done that, you will need to give your diagnosis and differential diagnosis to the patient based on the positive findings that you get from the examiner. Okay, is this clear for everyone? No, Dr. Tariq, for meniscal examination, only one, either Aplis or McMurray, not the both. Won't we have lack of time if we have to explain the normal knee look, feel, move? If we have to explain how will we give the commentary for that? Just the same. So if you're doing the normal knee examination, if you're doing the inspection, you will just say that on the right knee, there is no this on inspection. So same. It will waste the time, but that's the way to do the examination. You will always have to do the normal first, then the abnormal. If patient refuse to walk, then what to do, Dr. Rima? In examination, patient will not refuse to walk. But if they say that it's very painful, you can always escape that. There is no problem with that. You just need to tell the examiner that my patient is in severe pain on walking, so I would like to escape that. If patient can do active movement by themselves, do we need to do passive movement? Very good question, Dr. Tariq. We normally don't do it, but in here, we're actually palpating for any crepitation as well. It's not just doing the movement. So for this case, even if the patient is able to do the active movement without any problem, still we will do the passive movement. But in some other cases, it's not needed. Do we need to do collateral ligament, meniscal? No special test you need to do on the normal leg. For a special test, you just need to do it on the abnormal one. Which one is preferable, Apley or McMurray's? There is nothing like that. You can do any of these two. Either one is fine. McMurray will be easier because patient does not need to change the position and it will save a little bit of time. As I said that you don't need to do all procedure on the both knee, only the both knee you need to do is the inspection, palpation, and movement. The special test like patellar effusion, Clark test, all other special tests that we have done, that's only you need to do it on the affected knee. Okay. Yes, it's not just doing special test. Running commentary is a must, Dr. Aisha. All the physical examination you are doing, after each of the step, you need to give running commentary. So when you are doing the inspection, it is expected that you will give running commentary, like there is on right knee inspection, there is no swelling, no redness, no deformity, no bony deformity or muscle wasting. Okay, so this is the running commentary that you are giving. Again, when the patient was able to do the active movement of the knee, after that you will say that patient is able to do the active movement without any restriction. Then you do the passive movement, and then you're supposed to say to the examiner, the passive movement is normal without any crepitation. Then you do the special test like patellar bulge test and patellar tap test. After doing that, you will give running commentary to the examiner. Patellar tap test and bulge test is negative in this way. Yes, the drawer test is supposed to be done on the both knees to have some idea about the patient's knee. And Dr. Mariam, will the examiner give the findings while we are doing running commentary? Yes, while you are doing the running commentary, if there is anything positive, examiner will give you at that time, not at the end. Knee examination is one of the largest examinations, so you will have to do it multiple times to be able to finish it in time, because this is really hard to finish in time. What about hip and ankle joint? What's your name? I can't see your name. Your name is coming as Vivo. Can you change your name, doctor? So you don't need to do that in your exam. You just need to say that you would like to complete the knee and hip and ankle joint as a procedure. So you are not going to do that. You're just saying it at the end. All good? Let's move on to online explanation for medical student. So online explanation is quite easy because you'll just need to explain what you are doing. So whatever you have done so far, you just need to explain that. So initially, this is how we will start with the online exam. So we'll say that, hi, John. So let's say John is the medical student. So you can say that, hi, John, this is X, one of the RMO in this hospital. It is very nice to meet you. So John, I understand that you are a medical student. So which year you are in at the moment? So John says, yes, doctor, I'm fourth year. So you can say, well, that's great. It must be so exciting for you. Well, I'm very glad to show you one of my patients today. So we have got a 28 years old lady presented with a chronic right knee pain while running. I'm going to discuss with you on how to examine her knee joint. If you don't understand at any point, please do not hesitate to ask me again. So John, before we do a knee examination, first we should think what are the normal structures of a knee joint. So you can, now it's a long thing. Even if you don't do that, it's totally fine. It depends how fast you are when you are talking. If you are able to finish it in time, then you can explain what we are looking for in the knee joint. Otherwise, it's not that much important. So you can just say that, well, first we should think what are the normal structure of a knee joint. So you know that our knee joint is stabilized by some ligaments, tendons, and meniscus. We have got 4 ligaments, 2 cruciate, and also 2 collateral ligament, which prevents it from sliding side to side. And then there is a meniscus in between the 2 bones, which acts as a shock absorber. Now, anything that causes injury to this structure can eventually cause pain in the knee joint. Are you with me so far? Yes, doctor. Well, now before we start examining her knee joint, first we need to wash our hands, introduce ourselves, take a proper consent about the procedure, and request for an adequate exposure of the examining part, which in this case her lower lips. Next, we should also offer her some painkiller in case she is in pain now. Once she is given the consent, we will start with general appearance, looking for any protective posture, if she is comfortable or in pain or having any walking aids. So what you are doing, you are just doing the same thing, but explaining it. Then we will request her to stand and observe if she is able to bear weight on the painful leg. After that, now in here it depends. You can do the inspection or you can talk about the walking. So after that, we will ask the patient to walk and we will observe her gait for any antalgic or neuropathic gait and if the normal arm swing is preserved. Once the gait is assessed, we will do inspection of her knee joint from front, looking for any swelling, scar, redness, from side for any hyperflexion or extension deformity, and from the back for any Baker cyst in the popliteal fossa. Are you with me so far? You are understanding me? So every now and then, just ask the medical student if he is understanding you. After that, we will ask the patient to lie on her back for palpation of the knee joint. First, we will check the temperature with the dorsum of our hand for any increased warmth that can suggest joint infection or inflammation. Then we will check for tenderness over different parts of the knee joint, including these areas. Okay, so just give it a read. After palpation, we will check the active and passive movements of the knee joint. Knee has two movements, flexion and extension. We will ask the patient to bend the knee and then straighten it, and then we will do it as a passive movement. Once we have done the look, feel, and move, we will start the spatial test. First, we will assess for any knee joint effusion by patellar tap test and pulse test. So then you will actually need to explain it simple way. You don't need to explain a whole lot of things. In a simple way, explain what is patellar tap and what is patellar pulse test. Then we will do 3 spatial tests for patellar injury. So we will do Clark test for chondromalacia patella. Explain what is chondromalacia patella examination, then explain what is patellar heel test, then explain patellar apprehension test. It's very much well written here. If you give it a read, you will obviously understand how to talk about it. Then we do the cruciate ligament test, anterior and posterior drawer test. Again, we will explain that. We will explain the collateral ligament test, and at the end, either Aplis or McMurray's test. And then lastly, you will say, we will finish with examining one joint above and below, which in this case, the ankle joint and the hip joint. Lastly, we will thank the patient, discuss the findings and most likely diagnosis, and wash our hands. In these knee examinations, we will be looking for some of the differential diagnoses like chondromalacia patellae, patellar tendonitis, Osgood-Schlatter disease, osteoarthritis, rheumatoid arthritis, septic arthritis, or reactive arthritis. So if sometimes differential diagnosis comes, these are the DD that we are going to talk about. This is how we are going to explain chondromalacia patella. So chondromalacia patella means it's due to repetitive friction of the back of the patella against the lower part of the thigh bone, which is the femur. The covering of the patella, known as cartilage, undergoes some changes. That is what we call as chondromalacia patella. What is patellar tendonitis? It's the inflammation of the rope-like structure, which is called patellar tendon, that connects our kneecap to our shin bone. Okay. So that's the explanation of these 2 commonly asked cases. Any case can come in the exam. Sometimes Osgood-Schlatter disease comes. In Osgood-Schlatter disease, the only finding you might get is that tibial tuberosity tenderness, nothing else. Okay, no special test positive, no other abnormality, just tibial tuberosity tenderness. That's the time we would think about Osgood-Schlatter. So these are the common cases that come in exam. Usually, if you know how to do it properly, it's not very hard. For the online test, no, there will be no findings on the screen after physical examination. And many times they don't ask you to give the diagnosis for that because you can't find anything when you are explaining. If they want you to give the diagnosis and DD, then they will give you a very clear stem, and just by reading the stem, you will know what they're talking about, or sometimes they can give you findings after explanation. Okay, so that's all about knee examinations. I know that this is a lot to take, but knee examination is very hard, and we had to discuss it as that you understand it. And that's the basis of your physical examination. Once you understand how the face-to-face and online examination works, we are going to be more faster. Okay. Now let's take a 10-minute break. And after that, we are going to do another very hard physical examination. That's the wrist cut examination. Wrist cut is also commonly asked physical examination, but it is quite difficult to understand because a lot of structures are in the hand and you need to know all of those. So we'll come to that after 10-minute break. Give your brain a little bit time to rethink everything that we have discussed, and then we'll come back. Okay? 10-minute break, guys. Thank you. All right, everyone, let's start. Okay, so we're going to start with the wrist cut injury. Wrist cut injury is also quite important for exam, both face-to-face and online. So the case is something like that. This is also one of your first few cases in your handbook. So 30-year-old coming with a knife injury at the flexor aspect of the left wrist. Okay. Bleeding has stopped with pressure. Now, this one is actually the online examination format or question. So online examination, they will ask you that teach medical student about physical examination with anatomical landmark and give your diagnosis with reason. In case of face-to-face, they will just ask you to do the physical examination, give your running commentary to the examiner, and give diagnosis with reason. Okay, so as you can see that this patient has got quite a big knife cut injury, which has covered almost every part of the flexor aspect of the wrist. So around this area, you have got multiple things. Likely there could be a vessel injury. Your radial artery, ulnar artery can be injured. There is tendons, there is muscle, there is nerve. So any of these can be damaged with such a big knife cut injury, which you are going to assess with this examination. So first of all, with this kind of examination, first of all, we will do the wipe approach. Once we have done the wipe approach, because this patient just has got an injury like this, we will also need to assess the vitals from the examiner. So if it's a face-to-face, we will need to say that examiner, I would like to know the vitals of my patient. So I would like to know about his blood pressure, pulse, respiratory rate, and oxygen saturation. Okay, so assess the vitals to ensure he is hemodynamically stable. If patient is in pain, which he should be, so give some painkiller to the patient. So that will be your initial step like before. You will start with the general appearance. So in this case, general appearance is the same like before. You look that on general appearance, patient looks comfortable or in distress. This patient might be in distress because of this. You can say that on general appearance, patient looks in distress due to pain, but he is sitting comfortably or lying comfortably on the couch. Okay. Then you will start your inspection. So on inspection or on look, we will inspect on the palmar aspect and the dorsal aspect of the hand. So on the palmar aspect, what you are looking for, you can see that there is a longitudinal cut. This is not actually longitudinal, this is a transverse cut, sorry. So there is a transverse cut at the wrist about 5 centimeter in size, no active bleeding, no thinner or hypothinner wasting, and normal finger posture is maintained or lost. So what you are mainly looking for on this palmar aspect, you are looking, obviously there is a cut wound that you can see. So mainly inspect over this. So there is a transverse cut around the wrist about 5 centimeter in size. Look for any active bleeding. If there is any nerve damage like median nerve or ulnar nerve damage, then the thinner or hypothinner muscle can be wasted. So median nerve is supposed to supply the thinner eminence, and ulnar nerve is supposed to supply the hypothinner eminence. So if any of this nerve is damaged, you can get some wasting, which is unlikely given that it has just got injured. So it will take some time for wasting to come up. So you will not get that finding anyway, but still we should look for it. Now, just drop your hand on your table and look at your fingers. You will see that as a normal posture, your finger is always in a semi-flexed position. So just do that now. Just drop your hand like this on your table, just same like this. You will see that your finger is always in a semi-flexed position. And that is your normal finger posture. If the tendon which causing the flexion of your finger is somehow damaged, this semi-flexed posture of the fingers will be lost. And in this case, you can get this finding positive. So your role player can show to you that semi-flexed posture is no longer there, and you can see that fingers are just straight like this. And in that time, if you miss that line, that normal finger posture is lost, you can even get a very low mark in here, because this is a very specific finding of tendon injury. Once you have done the palmar aspect inspection, you move to the dorsal aspect. So you ask the patient, can you please turn over your hand for me? And then on the dorsal aspect, just a very regular one, you can say on comparison of both hands, I can't see any swelling and no scar, no redness, rash, no bony deformity or muscle wasting, no other sign of trauma, and no nail changes. So dorsal aspect, basically it will be normal because the injury is on the palmar aspect, but we are just checking for any other findings. So the inspection is done. After inspection, we move to the palpation or feel. Because this is an injury case, in palpation, we also need to assess vascular injury. So how to assess vascular injury? We should know that if there is normal warm temperature is there. So if you have got an adequate blood supply, the fingers should feel warm. The pulse should be palpable if there is no vascular injury, and capillary refilling time should be normal. Okay, so in here we don't need to assess for any tenderness. Obviously, patient had an injury, it will be tender there, and we are not going to make it any painful by doing that. So we'll just assess the temperature, pulse, and capillary refilling time. So temperature, just like before. Now, proximal to the cut, we don't do any examination. Distal to the cut, we will be assessing the temperature. So compare the right and left palmar aspect, assess for temperature, and comment that normal warm temperature on both hands. Or you can say that there is no cool periphery on the affected hand. Because if it is a cool periphery, that suggests that there is not adequate blood supply on that part. Then you will assess the pulse. So the pulse that we assess here is the radial pulse. Now you can see here, radial pulse will be difficult to assess, right? But it's still, if you can, just a little bit over here, you can try to palpate the radial pulse. But be very careful. Tell the patient that now I'm going to palpate just very closer to your injured area, but I would need to check for any pulse here to assess any damage or injury to your blood vessel. If you feel pain at any time, please let me know. I will stop right away. So you can try it to assess the radial pulse over here using your 3 finger. But if patient complains tenderness, just stop. Okay, don't do that. But doing or checking pulse over here, it doesn't matter because patient has an injury over here. Everything should be distal to that. So we are checking the radial pulse. Now, throughout our course or physical examination, we will show you how to check the radial pulse if you still don't know about it. But I'm hoping that you all know how to check the radial pulse anyway. Then capillary refilling time. In capillary refilling time, this is one of the most important exam to assess vascular damage or injury. So if you have got adequate blood supply to your fingers, capillary refilling time should be normal. So we apply a gentle pressure to the distal phalanx of the patient's thumb for 5 seconds. So just apply a gentle pressure on the patient's, like one of the nail bed. So let's say the thumb nail bed. So you apply a gentle pressure for 5 seconds and release it. In healthy individual, the normal color, which is the red color, should come back in less than 2 seconds. If it is more than 2 seconds, then it suggests reduced blood supply to that finger. Okay. Again, capillary refilling time, we will show you how to do that in other physical examination. Not today, but we are checking temperature, pulse, and capillary refilling time, and especially this will help you to assess for any vascular damage. Once you have done that, look, feel, then we do the movement. So the movement is extensive in here because movement helps you to find out if there is any nerve or tendon damage or even a muscle damage. So especially movement, we are going to do wrist movement because that also can be involved in this cut injury. So wrist movement, specific movements of the thumb, and also other finger movement. Now wrist has flexion and extension. Remember one thing, when the flexor aspect of your wrist is cut off, there is a chance that all the flexors will be affected. Extensor will be fine. So extensors are usually on your dorsal aspect and flexors are on the flexor aspect. Flexor aspect is this aspect. Okay. So that means all the flexions will be affected in this case. So wrist flexion can be affected. So loss of wrist flexion can be there in this case. We will come to that, like which causes wrist flexion, which causes finger flexion. We will come to that point. And how to do this also we will come to that. So wrist flexion and extension we will be doing. And finger has flexion, extension, abduction, adduction. Thumb has 5 specific movement: flexion, extension, abduction, adduction, and an opposition. Okay. So these are the main movement that we are going to do here. Let's come to wrist. And even before that, let me give you an idea that when you have got an injury to the flexor aspect of the wrist, the likely chance that your median and ulnar nerve can be damaged. Radial nerve supply the dorsal aspect, so it is unlikely that radial nerve will be injured in this kind of injury. So your medial nerve supplies 3.5 finger on the palmar aspect. So this is the palmar aspect. You can see it supplying the thinner eminence, thumb, index finger, middle finger, and half of the ring finger. So this lateral or this rest of this 1.5 finger will be supplied by the ulnar nerves. Okay, so both ulnar and median nerve can be damaged in this case. So now coming to the wrist movement. So for wrist movement, there is flexion and extension. You can always show the specific movement to the patient and patient can follow you. So you can just ask the patient, now we are going to assess your movement of the wrist. Will you please follow how I am doing it? That's one thing that easy to do. Or you can also ask the patient, will you please try to move or try to bend your wrist upwards just like me? So bending wrist upwards like a prayer sign, that's what we call as wrist extension. So this will be fine. Now then ask the patient, now will you please bend your wrist backwards just like me? So bending the wrist backwards or downwards. So upwards is wrist extension and downwards is wrist flexion. So when they're doing the wrist flexion, the injured wrist flexion can be affected. So patient might not be able to do the wrist flexion in this case. Okay, so that's the 2 movement of the wrist. And the wrist movement is usually done by flexor carpi ulnaris. And flexor carpi ulnaris, that's the muscle which can get damaged, especially if the tendon of flexor carpi ulnaris is damaged, then patient will not be able to do the wrist flexion. Okay. Now moving to the thumb. How to do the thumb movement and finger movement. For thumb, as we say that there are 5 movements. So again, you can show to the patient how to do the movement and patient can just follow your movement. So for flexion, we will ask the patient, so can you please try to touch your little finger with your thumb like me? So touching the little finger with the thumb, that's flexion. Then you can say, can you please move your thumb away from your index finger like me? So away from the index finger, that's extension. Then you can do abduction and adduction. For abduction, you ask the patient, can you please move your thumb towards the ceiling? Okay, so you don't need to do like this. You can just ask the patient, can you please move your thumb towards the ceiling? Towards the ceiling thumb movement is the abduction. Now we will show this abduction, how we normally do that in another video, is coming. Then adduction, can you please touch the index finger with your thumb like me? So touching the index finger with the thumb, that's adduction. And then we have got the opposition. In opposition, patient actually needs to touch the little finger. For flexion, they don't need to touch the little finger. They can just say that, can you please bend your thumb towards your little finger? So bending it towards the little finger is flexion. But when you ask the patient to touch the little finger with the thumb, that becomes opposition. Okay. So these are the 5 thumb movement that we are going to do: flexion, extension, abduction, adduction, and opposition. Now, in this case, what can be damaged? In this case, you can get loss of thumb flexion, abduction, adduction, and opposition. Only the extension that can be spared, and all other thumb movement can be damaged. Now, we will come to the point which muscle actually helps with this kind of movements later on. After that, we move to the finger. So finger again has got 4 movements. If you look at here, I will come to the flexion extension later on. Finger abduction means spreading the fingers like this, okay? And adduction means keeping it closed like this. Let's have a look. Okay, I don't have the video for flexion extension. Flexion extension is very easy. We will show that hand movement again in our hand examination, because there is a whole lot of hand examination in our I think 3rd physical examination class. So we will go through the hand examination again with a very good video. So flexion of the finger means just ask the patient to make a fist. So when they make a fist, they are doing finger flexion, and then ask them to straight it, that finger extension. Then ask the patient to spread the finger, that's abduction, and then close the finger, that's adduction. Okay, so these are the finger movements that we are going to assess. In this case, loss of finger flexion can be there, because finger flexion will be given by this FDP and FDS. Now coming to this point, which is really confusing, you will find out flexor digitorum profundus and flexor digitorum superficialis. These are the 2 tendons which helps you to do the finger flexion, and that can be damaged in this case. As you can see on this picture, you see the FDS, flexor digitorum superficialis, and FDP. These 2 tendons helps the finger flexion. Now, the trouble in here is that this profundus helps your finger flexion in both DIP and PIP joint. So that's the DIP and this is the DIP and this is the PIP joint. So flexor digitorum profundus, FDP, helps your finger flexion in both DIP and PIP joint. and flexor digitorum superficialis only helps flexion of the PIP joint. Now, you do understand the problem that if the patient is unable to do the PIP joint flexion, then how will you know which tendon has been damaged? Because both FDP and FDS helps with PIP joint flexion. Are you guys getting my point? Yeah. So as we discussed that your FDP, flexor digitorum profundus, helps to flex your finger in both PIP and DIP joint. So this is DIP and this is PIP. Okay. So FDP helps. So FDP helps with movement of PIP and DIP both. And just flexor digitorum superficialis helps with just PIP movement. Now, if you have got a patient who can't do the PIP flexion, then how will you know that which tendon has been damaged? Because both FDP and FDS helps with PIP joint flexion. Now, to differentiate which tendon has been damaged, there is a specific test that we do. So to come to that point, that's the reason why I have to discuss a lot of things. So let's have a look on this video, how we access that.
When a patient has an injury that may...
So you can see over here, this is the normal semi-flexed posture of the finger, which can be lost if your tendon is damaged over here.
have involved the flexors of the fingers. We need to examine those. There are two flexors to each finger. One is the FDP, the flexor digitorum profundus, and the other is the FDS, flexor digitorum superficialis. So the first thing to look at is whether they have a normal cascade. So the normal cascade we can see here, when the patient is relaxed, the fingers are flexed at different amounts. If the patient is, for some reason, unable to comply with a full examination, for instance, in a very small child or someone who is unconscious, then the thing to do is to squeeze the forearm, and you can usually then get gross composite flexion. You move around a little bit, you should then get all four fingers in, and you can see whether or not there is continuity of the flexor. Specific examination of them in a patient who is able to comply with you. As I say, there are two tendons. We want to examine both the FDP and the FDS. FDP is a mass action muscle in which one muscle has four tendons and flexes all four fingers.
Okay, so come to the point first. So FDP it's a mass action muscle. So one tendon goes to the all fingers and flexes all of your fingers. Okay, so it's a single tendon which is supplying the all other four fingers and helping with your finger flexion.
So to examine the FDP of the index finger, I would stabilise the middle phalanx and ask the patient, can you bend down the tip of your finger for me, okay, and press against me. So flexion against resistance of the FDP. That one's easier. The FDS.
So FDP is easier, right? Because for FDP, you can just assess any of the finger flexion. So you can just block the PIP joint and ask the patient to flex the DIP joint. Okay, now for the exam, you don't need to do this part because you have already done the finger flexion extension. We just need to know that if a patient is unable to do the finger flexion, that's the time we need to know that if the FDP or FDS has been damaged. Now again, if the patient is able to do PIP joint movement, then we are not bothered. That means if PIP joint is able to do, that means the FDS or FDP is working anyway. All right. Again, if FDP joint, if the DIP joint is able to flex properly, we know that FDP is working fully. Again, let's have a look to this. Don't get confused.
So to examine the FDP of the index finger, I would stabilise the middle phalanx and ask the patient, can you bend down the tip of your finger for me, okay, and press against me.
So to assess the FDP, we can just ask the patient to bend their last joint or DIP joint. So ask the patient, can you please bend your index finger for me while you are resisting the PIP joint, right?
So flexion against resistance of the FDP. That one's easier. The FDS, on the other hand, flexes at the proximal interphalangeal joint, but so does the FDP. So in order to isolate the FDS flexion, we have to handicap the FDP. And because it's a mass action muscle, we can do that by holding all the other fingers straight and asking the patient again to bend that finger down. Now, because the FDP is a mass action muscle and we've held it out in full flexion, when she bends the proximal interphalangeal joint, the only tendon that can be doing that is the FDS. If you bend it down and hold it for me, I can prove.
Did you guys understand the point? It's a very, very well demonstrated. So you can understand here that FDP is a mass action muscle. So what you are doing that you are just blocking that FDP just by doing that. Now, if a patient is able to flex the index finger PIP, that means now just FDS is working, not the FDP. Okay, is this clear, guys? Good. So that's the tricky part for this particular case, that where people get a little bit confused. Now, with this video, it is very, very clear that how we are going to assess that if the patient having FDS or FDP injury. And only time we need to know, or we need to do that during our exam, if patient is unable to do the finger flexion. And that's very likely chance that in this case you can get, because most likely finger flexion tendon can be damaged in here. So if finger flexion is not possible, that's the time you need to assess one by one. You can assess the DIP joint or FDP, just like how the video has done it. So you can just hold the index finger PIP joint and ask the patient to bend the DIP joint. If the patient able to bend the DIP joint, that means FDP is working. And then because FDP is a mass action muscle, you can easily block the FDP action, okay, by holding all other fingers with your other hand and just ask the patient to bend the index finger. If the patient is able to bend the index finger while you are resisting the FDP, that means just the FDS is working, okay? So that's the basis of this FDP-FDS difference, which examiner loves if you do in the exam. So you will have to do it in case this is a finding, okay? So this is the movement: wrist flexion, extension, finger flexion, extension, abduction, adduction, and thumb. And once you have done that, while you are doing the finger flexion, then you will find out patient is unable to do the finger flexion. Then you will need to go for this tendon checkup for FDP and FDS. So you can see the mass action thing. So you can see over here that, see the flexor digitorum profundus. It's a mass action muscle. So from one, all the tendons coming up. Now this is the muscle that we are talking about. Your wrist flexion is mainly given by flexor carpi ulnaris and radialis. For finger, flexion is done by FDS and FDP. And also for the thumb flexion is done by flexor profundum, flexor pollicis longus. Okay. Abduction, adduction done by interosseous muscle. Now, why we need to know that in case any of this muscle is not working, you will need to say in the exam. Like let's say you ask the patient to spread the fingers. That's finger abduction, and then close the fingers, adduction. If patient is unable to do the finger abduction, adduction, then the likely chance that either the interosseous muscle or the ulnar nerve, which helps with this muscle movement, is damaged. So either the muscle or the nerve has been damaged. Okay, so that's the reason that why we need to know this muscle name with their nerve supply. And unfortunately, in face-to-face exams, sometimes examiner asks you, so your patient is unable to do the finger abduction, adduction. So what do you think has been injured? Okay, so that's the tricky part, and it's very difficult to remember. It's very well written here, so please remember these things. And you can see that in the thumb, abduction is done by this muscle, adduction this muscle, opposition. It's obviously median and ulnar nerve is usually the supplier of thumb. Okay, so all the wrist, finger, thumb movements will be done by median and ulnar nerve anyway. So the nerve will be supplying these muscles, but we need to know the nerve injuries, we need to know the muscle injuries as well, both. So make sure you remember this muscle and nerves for this wrist, finger, and thumb. How to differentiate between FDP and FDS? If you need to explain it to the medical student, it is written in here, you can go through that. And this was the FDP muscle. So flexor digitorum profundus, you can see the muscle becomes tendon at the end, and this tendon is a mass action muscle, and it goes to all of your 4 tendons. Okay, so if you block this, the FDP will be blocked. So far we have done look, feel, and move. After that, we will go for sensation. For sensation, okay, good question. Do we have to check FDS function in all fingers? No need. Just one finger is more than enough. Okay. Again, like it is very unusually given in the exam that FDS injury particularly, most likely they don't give you. But if you see that patient is unable to do the particular PIP joint movement, then yes, you will have to do individual fingers. But for the purpose of exam, you don't need to do that. Okay, just do one. That should be more than enough. Now for the sensation, so how to do the sensation examination, we will go through that in our neurological exam. So please don't bother with that right now. Just make sure that we do the sensation by cotton wool and pin prick. So using the cotton wool and pin prick, we are going to check the sensation on the hands distal to the injury. So we are checking it on thinner and hypothinner eminence for median and ulnar nerve. And we will check index finger for median nerve, little finger for ulnar nerve, and we can just check the anatomical snap box for radial nerve, which is not very important, but still you can check it. So in this case, you can get loss of sensation in the median and ulnar nerve distribution, which is this. Okay, so check the sensation over the thinner and thumb, that's for median nerve, little finger and hypothinner for ulnar nerve, and anatomical snap box over here for radial nerve. Okay, and we do it for cotton wool and pin prick. How we do that? That's a whole amount of discussion. We will do that in our neurological class. And also it is written in here, you can go through that, light touch pin prick. Now, after sensation, we are doing the power. So now sensation and power mainly will assess the nerve issue. The movement mainly assess the muscle and tendon damage. Okay, so everything we are doing is to assess the injury. So to check the power, especially we are mainly checking the power of median nerve and ulnar nerve. Okay, and also we are checking for any injury to anything specific like C8 and T1. Okay, so for C8 injury, like for C8 nerve root injury, you can ask the patient to squeeze your finger with your fist, and for T1 spread your finger. Now, how we do the C8 T1 power? Again, we are going to do that in our hand or upper limb neurological exam. So keep that for that class. Just remember that we are going to assess the C8 T1 power here. Even more than C8 T1, this two special power test is important to check for median nerve and ulnar nerve damage. For median nerve, we do the pen touch test, and for ulnar nerve, we do Froment sign or card test. So these are the two last power examination that we need to do. So for median nerve, don't know like why the video is not coming over here. So all of this actually, the videos were there. Just 1 second. Let's see if we can show you.
Touch the tip of the pollicis brevis function. This is the pen test.
So this is the pen touch test that we do.
Test, which will be.
So what we do, you ask the patient to touch your pen with the thumb. So while patient is touching your pen with the thumb, they're actually doing the thumb abduction. And thumb abduction is a purely median nerve action. Okay. Now, that's why we do this pen touch test to assess the median nerve. So we just ask the patient, can you please touch the tip of the pen with your thumb?
We
So
will
while
try to
patient
see
is
the
doing
abductor
that,
pollicis brevis function. The patient is asked to touch the tip of the pen with the tip of his thumb. नीचे ले एक और कर टच कर. This is the pen test.
okay, so that's one thing. Now, if you are not comfortable with the pen touch test, you can just assess the power of the thumb abduction. So just ask the patient to do the movement of this thumb against your hand. So if you do it against your pressure, that's also the same thing. So any of this, either you do the pen touch test or you do the resisted thumb abduction, that will do the test. That's mainly for median nerve. Now for ulnar nerve, we do a card test, or this is also known as Froment sign. So what you normally do for Froment sign is that, see the piece of paper here. So you ask the patient to put this paper in between his thumb and index finger, just like this. And you also will do the same. And then you will try to pull the paper out of this and ask the patient to resist that. If the patient is able to resist your pulling, that means the ulnar nerve is good enough. And ulnar nerve, in this case, you are actually assessing the thumb adduction power and also the interosseous muscle power. So that's also given by ulnar nerve. So to assess the ulnar nerve, you do this test. Two things can happen. If the ulnar nerve is weak, then you can easily pull out the paper from the affected side, or sometimes you will be also able to notice that their thumb might get hyperflexed. Now, how we look for that? Let's have a look. See, the right side is weak. Now look at this one. This is called positive pinch with distal phalanx. See, the distal phalanx is getting hyperflexed. So patient is actually overcompensating by doing this hyperflexion. So if you also see this hyperflexion of the DIP joint, while you are trying to pull it, patient's ulnar nerve is weak. So just to like show that he has the power, he's doing this DIP joint hyperflexion. So that's also positive card test or Froment sign. So these are the two tests that we are going to do to assess the median nerve and ulnar nerve power. So because these are the two nerves which is possibly can get damaged, this will confirm your diagnosis as well. So with the power, you are just doing this pen touch test or resisted thumb abduction and this Froment sign or the card test. After you have done that, so we have done look, feel, move, sensation, and power. Based on your finding, you can give the diagnosis that it's, if most of the time this is the finding you get, it's a severe deep knife wound injury of the wrist, severing all flexor tendon of the wrist and hand, severing median and ulnar nerve, and likely injury to the radial artery or ulnar artery. This is the condition 050 in your handbook. You can also give it a read. But as we have discussed that this should be your format of doing the physical examination in this case. So you will start with the general appearance, vitals, painkiller, all of those. Then in the look, palmar aspect, dorsal aspect. Okay, palmar and dorsal. Don't forget that this finger posture can be lost here. In the field, we assess the vascular damage by assessing temperature, pulse, capillary refilling time. Then we do the movement, which is the most difficult one. So wrist flexion extension, finger has 4 movement, thumb has 5 movement. And don't forget what you can find in this case. Wrist flexion, finger flexion can be lost. And in the thumb, everything can be lost except the extension. Because all of these are supplied by the flexor muscles and median and ulnar nerve. Once you get that finger flexion is no longer possible, then you assess the FDP and FDS. One by one, check the FDP and then the FDS. And then you will check the sensation and power. So in the sensation, median and ulnar nerve, and then you do the power. If you even just do the pen touch and Froment side, that should be enough for this case. Okay. In the online format, exactly the same thing, and you will just need to explain each and everything that we have done. It's very well written in here that how we do each and everything. You just need to give it a read in your own time. Okay. Any question in this case, guys? Now you should have got the idea that this is actually not that easy. Like the cages that we do, it is not that hard, but physical examination, it's a lot of reading, lot of preparation needed, right? So what I would suggest you from today, start doing this as a practice every day with your partner. If you don't have anyone, at least do it on a dummy or on a doll or even on a pillow, but just do it. Okay. And if most of you are going for face-to-face exam anyway, so just make sure you are comfortable with the running commentary and everything about the step-by-step approach. Yes, Dr. Tin. So if median and ulnar nerve is severed, then sensation will be lost on the palmar aspect as well. Like whole palmar aspect will have no sensation. Yes, Dr. Jahra, in online exam, we will also mention the name of these tendons and ligament as much as you can. So like it's a good idea. You can always explain. See this one, then let's say that's this one. Then we will assess the thumb movement by asking the patient to do flexion, extension, abduction, adduction, and opposition. You can also show it to the medical student how you are doing this. Then you can say abductor pollicis brevis can impair the thumb abduction, whereas adductor pollicis can impair the thumb adduction. So a little bit, if you can explain, that will really give a good amount of good mark in this case. An examiner usually wants to know a little bit that you know this muscles is supplying this one, this nerve is supplying this part. So at least you don't need to do everything. That in that way it will become very haphazard if you say each and everything that we have written here. Like in here you can see that I have just written thumb abduction and adduction. That's all that I have written. You can always say that in this case, if you can come over here, I will show you what we normally would say in here. So come to the thumb. You can say here, in this case, thumb abduction, adduction, and opposition can be impaired if the patient has median and ulnar nerve damage, or if the abductor or adductor pollicis is injured. So you can just explain in this way. Same with the finger, you can, or in the wrist, you can say that then we will be assessing the wrist flexion and extension. We will ask the patient to bend their wrist upwards and downwards to assess that. In this case of injury, wrist flexion can be injured or wrist flexion can be affected because the flexor carpi radialis supplies the wrist flexion, and with this cut injury, this is also a possibility that can happen. So you just need to explain in this way a little bit so that examiner and the medical student knows that what you are doing. I have written the most of the important things that you need to say. You can always add or include some of the other extra thing as your convenience. So the thumb movement, if we want to show you, Dr. Naharuman. So this is the thumb movement. As we say that the thumb movement again will be discussed in our hand examination. So you will see the specific movement anyway. So the thumb movement has flexion. So this is the flexion where you ask the patient to move their thumb towards the little finger. Thumb extension is moving the thumb away from the index finger. Opposition is touching the thumb with the little finger. Abduction is asking the patient to move the ceiling, and adduction is asking the patient to touch the index finger with their thumb. All right, guys, so that should be all for tonight. I hope that you enjoyed the class. I hope that you understood how the physical examination should be done. And also, I hope that you understand the importance of physical exam to pass this AMC clinical. All right. Now, as you understand that for those of you who are already part of the course, by this time, you should get physical examination pages access in your portal. So in case you have made the full payment and you haven't got the physical examination notes in your portal yet, please make sure you send us inbox or send us a message in the messenger, or at least email to us so that we can have a look, because sometimes it can be missed by the team. So just reach to us, we will fix it. Okay. All good. Thank you, everyone. Have a good night. We'll see you in the next class. Bye. And in the next class, we are going to start with the lower limb musculoskeletal exam and neurological exam. So we'll finish the ankle examination and ankle and foot examination, and then most likely we will move towards the lower limb neurological exam. Okay. Thank you all. Have a good night. Bye.